Welcome everyone to our CTMS webinar. My name is Joy Koo and I'm a member of the CTMS Executive Committee, and I'll be serving as the moderator for the webinar today. I'm pleased to welcome today's presenter, Allison Larsen from UC San Diego. Next slide, please. So for those of you who aren't familiar with the Committee on Credible Practice of Modeling and Simulation in Healthcare, better known as CTMS, it's an initiative that was established under IMAG and the Multi-Scale Modeling Consortium, which consists of a number of government agencies as you see listed there. As our name implies, our goal is to establish good practices for the use of simulation and modeling in healthcare. We see tremendous potential for these technologies to support research, clinical decision-making, and education in healthcare, and really want to ensure that this potential is realized. So important first step towards this goal is to establish how to use this technology appropriately and to enhance its credibility. Next slide. We hope that this webinar is going to help us move towards that goal. There are two main goals. One is we hope that providing examples of how others have translated their modeling and simulation research into clinical use, that we can begin to identify different pathways and guidelines to help others achieve similar results. And secondly, we hope that these webinars engage the community in discussions about best practices for modeling and simulation, particularly in terms of adoption within healthcare. Next slide, please. Before we get started, I just want to give you a few reminders about the webinar format. We're going to take questions at the end of the presentation using a Q&A panel, so it'll all be text-based. And if you do need additional help, you can consult the guide that's listed on that website there. Next slide. And now I'd like to go ahead and introduce Allison. Allison Larsen, she's currently an associate professor and Jacobs faculty fellow in the Mechanical and Aerospace Engineering Department at the University of California, San Diego. She graduated with a bachelor's degree in mechanical engineering from Princeton University and a PhD in mechanical engineering from Stanford. She went on to a postdoc fellowship at Stanford in bioengineering and pediatric cardiology, working with Charles Taylor and Jeffrey Feinstein. Allison's the recipient of a number of awards, including Burroughs Wellcome Fund Career Award at the Scientific Interface, as well as an NSF Career Award, and she's a member of an International Leduc Foundation Network of Excellence. She's published over 60 peer-reviewed journal papers, and her lab has received funding from the NSF, NIH, and several private foundations. Her work focuses on the development of numerical methods for simulation of cardiovascular blood flow problems, medical device design, and the application of optimization to large-scale fluid mechanics simulations, and the use of engineering tools to impact patient care in cardiovascular surgery and congenital heart disease. So welcome, Allison. We look forward to your presentation.
Thanks so much, Joy, for the introduction, and also thank you to the committee for the invitation to speak today. My goal for today's webinar is to really tell you two vignettes from my lab's attempt to translate some of our simulation-based designs for congenital heart disease into the clinic. And so I'm going to tell you one story of a surgical concept that has been translated into the clinic, and then a second one that we're in the process of working towards translation, and then, hopefully we can provide some perspectives on some of the differences and some of the challenges that we've faced along the way. So I wanted to start by giving a little bit of background on congenital heart disease. It's actually something that we maybe don't hear as much about as we possibly should, but it's actually the most common birth defect, affecting about 1 in 100 newborn babies. It's a very heterogeneous population of patients with over 40 different types of diagnoses for different types of congenital heart diseases, and totaling about 40,000 births per year in the U.S. Congenital heart disease continues to be the leading cause of infant death in the U.S., and there's actually a growing population of adults now living with these conditions as we get better and better at treating congenital heart diseases in infancy and childhood. those patients are now growing into adulthood, and there are more than 2 million Americans now living with some form of congenital heart defect. There are about twice as many children who die from congenital heart disease as from all childhood cancers combined, and it poses a significant burden on the healthcare system in terms of cost, with a cost of inpatient surgery to repair these defects totaling more than $2 billion a year. So what I'm going to talk about today involves patient-specific modeling, and this is a process where we take a set of patient image data. We typically work with CT data or MRI data, and we build custom three-dimensional models from that image data through image segmentation. We then use an unstructured mesh to create a geometric mesh, and then we run specialized flow simulations using appropriate boundary conditions to model the circulatory physiology. So this process is something we can keep in mind as we go through the rest of the talk. I wanted to also give an overview of what I view as the emerging paradigms for cardiovascular simulation. What I'm going to be talking about today mostly falls in this first category. So this is using simulations for virtual surgery and treatment planning. And we can think of this as providing tools for personalized medicine, in that we often want to try to customize the appropriate surgery for a particular patient or customize a device implantation. We're also, and I'm going to be talking about this today, using simulation as a method for testing novel surgical concepts. And this is really providing a tool to quantitatively test these concepts before we go down the road of animal models or patient studies. And then finally, we're trying to develop quantitative tools for predicting post-surgical conditions. But in addition to that, just to give sort of a bigger picture view, I think simulations are also emerging as a way to examine fundamental disease mechanisms, including vascular growth and remodeling, and also mechanobiology and what is their interplay with hemodynamics and mechanics. How can we incorporate these things into simulations to make better predictions and more relevant predictions to the clinic? And then also thinking about simulations as a way of augmenting clinical imaging. So we can get a lot of very beautiful anatomic information from medical imaging. And simulations provide now another layer on top of that, where we can start to look at flow, stresses, mechanical deformations, et cetera. So I wanted to first begin by giving sort of a big picture of what I view as some of the challenges of clinical translation from the point of view of engineers, and particularly in my case, fluid mechanics or mechanical engineers working on clinical translation and simulation. So some of the common pitfalls might be things like we tend to have very sophisticated simulation tools, and so we tend to have very large hammers, and I think one of the pitfalls is sometimes people fall into looking for nails to strike with their hammer rather than sort of looking for what is the biggest clinical need. And that leads into the need to really truly understand the clinical needs that we're trying to solve. We need to really have good communication with clinicians. I've experienced both extremes, where first clinicians may think that we have tools that can solve everything, or on the flip side of that, they may take them a while to realize that we do have tools that are relevant to their clinical challenges. Another common pitfall that I observe sort of in watching the field as a whole is I think many engineers think that clinicians will just give them a problem and then they go away to solve it, but I think it really requires constant communication. And then another pitfall that we as engineers maybe need to avoid is we may like to get too wrapped up in our methodology and our methodological details that sometimes we can fail to see the big picture of the patients and challenges that we're trying to solve. So a few solutions that that I've found from from my experience. One is really to embed yourself in the clinical environment, and so that means sending our students into the clinic, going in to observe procedures, surgeries, catheterization, patient tests that they undergo. Also educating clinicians about our tools, and of course this requires time and willingness on the part of clinicians. One of my collaborators likes to say that we each need to know enough to make ourselves dangerous, meaning we need to know enough about the clinical side and they need to know enough about the engineering side. Another solution is we often need to bring in other collaborators to satisfy a larger vision of how we're going to translate things. We need to maintain continuous communication with clinicians, not just sort of a one-time translation of here's our need, go away and solve it, but really continuous, constant communication, and again, observing clinical procedures regularly. So today I'm going to talk about, as I said, two sort of vignettes of how we've attempted clinical translation, and these are both related to a particular type of patient with congenital heart defect called single ventricle physiology. So single ventricle patients are among the most challenging group of patients for pediatric cardiologists to treat. What you can see here is the normal heart, which has two pumping chambers, right and left ventricle, and compared to a baby that's born with hypoplastic left heart syndrome, in which one of the ventricles is malformed and therefore doesn't serve as an adequate pumping chamber. And so these patients have to undergo 3 open heart surgeries starting as infants, and then, so I'll step you through what those 3 surgeries are. So these patients are able to survive following those 3 surgeries, but they encounter a number of problems as they grow up. One thing I should point out is that these conditions, single ventricle conditions, are typically fatal with no intervention. They leave the patient severely cyanotic or blue, lack of oxygen. They require 3 open chest surgeries starting as neonates. And then as the patients are growing, they encounter issues, clinical morbidities, and sometimes mortality, including exercise intolerance, protein-losing enteropathy, heart arrhythmias, thrombosis, heart failure, sometimes transplantation, and other issues. So I mentioned that these patients undergo 3 open heart surgeries. The first one, which is shown here, is called the Blalock-Taussig shunt, or Norwood procedure. And this involves typically reconstruction of the aorta, so the aortic arch, and then insertion of a small shunt. And this is typically a 3 to 4 millimeter shunt. And the important thing to realize here is that this shunt then provides the baby's only source of oxygenated blood flow. So this is done in a neonate, and then at about 3 months of age, they typically perform stage 2, which is called a Glenn surgery. And this surgery connects the superior vena cava here, so this is the venous return from the upper body to the pulmonary arteries. And then this is followed at age 3 to 4 by a Fontanne surgery. And the Fontanne surgery aims to connect both, so the entire venous return to the pulmonary arteries. So we already have the Glenn superior connection here, and then they add on to this the inferior vena cava connection to the pulmonary arteries. And this results in what's shown here, which is essentially a T-shaped junction. And so the brilliance of this circulation, which was developed in the 70s by Fontanne and others, is that the heart only visits the blood only visits the heart once on its way around the circulation. So here you have now the right ventricle used as the systemic pumping chamber, That sends blood out the aorta to the body. It comes back through the vena cava and to the pulmonary arteries without visiting the heart again. And so the blood then goes passively to the pulmonary arteries. And so we've been examining this Fontanne junction from an engineering point of view, and also, from a point of view of doing simulations and thinking about how we could better design a junction for this Fontanne connection that's shown here. So one of the clinical challenges that's faced with these patients is something called pulmonary arteriovenous malformations. This is a relatively serious clinical complication, and it's caused by the lack of a yet unknown hepatic factor. So this is a factor that's coming from the liver and is delivered to the lungs via this IVC pathway coming, so the inflow from the lower body portion of the Fontanne junction. And so it's been shown clinically in other studies that the lack of this flow from the lower body containing this hepatic factor can lead to the development of these what are called PAVMs. And this is essentially like a short circuit in the lung that shunts the blood over before it has a chance to pick up oxygen. And so from a design point of view, thinking about this from a fluid mechanics engineering perspective, a design criteria would be to even out this hepatic flow distribution to both the right and left lungs. And so that was one of the goals as we were thinking about new designs. And so in about 2006, we came up with this Y-graft design, and we had, so this is a design that's meant to replace the traditional Fontanne junction. So what you have here is the traditional T-junction design, and this geometry that you're seeing here was actually reconstructed directly from the image data of a Fontanne patient. So this is the surgery that this patient has. And then what we can do in simulation is actually do a virtual surgery where we test out different design alternatives. And so what I'm showing here is an offset design. Now this was proposed actually by engineers. So there's a group in Milan, Italy, that were really pioneers in developing a lot of these computational methods. And they studied energy loss and proposed this offset design. And so this is also one that's very commonly done in the clinic. Now, the disadvantage, potentially disadvantage of the offset design is that it may tend to skew this hepatic flow distribution to one lung. So while it is successful in reducing energy loss, it may have the detrimental effect of skewing the flow distribution. So as a way of getting sort of the best of both worlds, meaning avoiding the collision of blood flow that increases energy loss, but also distributing the hepatic flow evenly to both sides, we proposed doing what we call a Y-graft surgery. And we used simulation to test two different alternative designs for this, this graft. So what you see here is a 9mm graft off-the-shelf design and a 12mm area-preserving graft that we proposed. I wanted to also make the point here that communication with clinicians is extremely important. So as we were starting to develop this Y-graft concept, we really iterated with the clinicians. So it's not that they sort of told us the problem and we went away and solved it, but we had pretty constant communication as we were developing this. So I really think it's important to modify your design and your methodological approach as needed, and also incorporate clinician feedback and questions. So some of the questions that I'm going to show you really arose out of this iterative communication process. So as we were developing the Y-graft and in discussion with the clinicians, we came up with several questions that we needed to answer. One was, is it possible to improve the hepatic flow distribution using a Y-graft? The second one, and this really arose out of discussions with the surgeon Mohan Reddy, who performed the first Y-graft surgeries. As he was constructing the grafts, in preparation to the surgery, we started asking questions. Well, should some patients have a graft with unequal branches? Should all patients have the same design? And then in thinking about the energy loss question, does the Y-graft actually reduce workload on the heart as we originally hypothesized? And finally, and probably most importantly, is the surgery even technically feasible? And so, the point I want to make here is that these questions evolved really interactively as we learned more, both from the clinic and from the simulation side. So I just wanted to give you an idea of the type of virtual surgery that we performed. So what you have here are 5 stage 2 Glenn patients. So these were constructed directly from image data for the Glenn surgery. And then we virtually converted these to, for each patient, using several different surgical options. So we performed a virtual surgery. Each patient had a Y-graft, a T-junction, and an offset in simulation. And then for some patients, and in consulting with our surgeon, we sent him the models, he examined them, he asked questions, and then proposed, well, maybe for this patient I could do it this way or this way, can you go and test these different options for us? And so for some patients like this one here, this patient had a stenosis, and so we tested the options of attaching the limb of the Y-graft in different ways to test, how that might play out in the clinic. And so, I'm not going to get into too much details on the results, but we were able to show improvements in hepatic flow distribution. So this is a percentage difference from the theoretical optimum, which was a 50-50 distribution. And so the Y-graft outperformed the other 2 design options. And we were also able to show reduction in energy loss, which increased with increasing exercise level. We also did design optimization on the Y-graft. So we were able to hook up our Navier-Stokes solver to an optimization algorithm and then perform automated design. And these are tools that I think are really going to be useful in propelling sort of simulation-based design into real clinical applications. And so this was done in an attempt to answer our question that I mentioned before about whether unequal branches could improve hepatic flow distribution in some patients. And actually, we were surprised to find out that after performing optimization on a number of different conditions, that it's actually not likely that unequal branches would be needed. And so we concluded from this that we should proceed with having equal-sized branches in our design as we went forward into the clinical studies. This is an example of a case where we were able to improve an initial design through optimization. So there was one patient that had about a 70-30 flow split, and we wanted to get it closer to 50-50. So we did optimization in an idealized model, showed that we got closer to 50-50, then put that back in the patient-specific model and confirmed that we were still hitting our target. And so this was a case where our hepatic flow distribution was improved in an underperforming case. We also worked with Francesco Migliavacca and Giancarlo Pinotti in Milan, Italy, and this was through a collaboration done funded by the Leduc Foundation to determine whether the workload on the heart might be affected by changing these different designs. And so it had been hypothesized before, even by us and others, that perhaps changing to an offset or a Y-graft design would reduce the energy loss enough that we could actually alleviate some of the workload on the heart. And contrary to our hypothesis, we actually found that this was not true in our simulations. Our PV loop actually, so this is the pressure volume loop of the heart, from the heart model in our simulation. It actually remained unchanged when we put in the T, the offset, and the Y-graft designs. So I wanted to then, outline a few of the goals of our simulation studies that, really accompany our clinical translation goals. And so, some of the things that we've been exploring and will continue to explore related to the Y-graft were to evaluate robustness with respect to surgical implementation and physiologic conditions. So it's very important to, not only optimize the design for a particular geometry, but knowing that the surgeon is likely not going to implant exactly the geometry that we intended, we want to make sure that slight deviations from that geometry would not adversely affect the results. And then, it's very important to evaluate the impact on physiology and cardiac workload, which we've done through these multi-scale modeling tools. We've also done some work to try to evaluate risk of blood clots and thrombosis, and I'll show you a little bit more about that. And using optimization to really try to refine our design prior to a larger clinical study. So we have been successful in translating this design, the Y-graft design, to the clinic. The first surgeries were performed in June of 2010 at Lucile Packard Children's Hospital at Stanford by Dr. Mohan Reddy. And so we started by conducting a clinical pilot study, and the goal of that study was to determine technical feasibility. And I should also mention here that this design was also adopted by Kurt Kanner, who's a surgeon at Emory, and also motivated by some of the work of Ajit Yoganathan's group at Georgia Tech, who also did some early simulations of this design. And they have also done their own clinical studies with good results. And I'm happy to answer questions about that as well. So our Stanford pilot trial was intended to assess the technical feasibility and non-inferiority of the Y-graft extracardiac Fontanne surgery. It was a single institution, single surgeon pilot study. All cases were done without cardiopulmonary bypass, which is the norm for that institution. And we had one exclusion criteria, which was a history of clotting disorder or clotting event. There was no change in INR target or postoperative care. However, we did perform some additional imaging on these patients since it was a new procedure. So they had an MRI preferably before leaving the hospital, and then also an option to come back for an additional MRI at 6 months to 1 year. Again, primary endpoint technical feasibility, and secondary endpoints chest tube drainage and length of stay. And so we have just recently published the preliminary clinical findings of the first set of patients. So we had 7 consecutive patients eligible, 6 who received the Y-graft, 1 patient had unfavorable anatomy. The grafts were constructed by hand in the operating room by Dr. Reddy using Gore-Tex tube grafts. And so I think it's important to note here that this did not require creation of a new FDA-approved device, because he constructed the grafts out of all FDA-approved materials, i.e. the Gore-Tex tubes, 8mm trunk and 12mm branches that were hand sewn together. All of the surgeries were technically successful on the 6 patients. There were 3 adverse events that we've reported in our clinical outcomes paper. 1 patient was found to have plastic bronchitis, but it was not felt to be due to the Y-graft because it was subsequently reported that he had had symptoms, this patient had had symptoms prior to the Fontanne. There was 1 patient with thrombus formation in the aortic arch, but this was again felt not to be due to the Y-graft since it was in an entirely different region. There was 1 adverse event that probably was linked to the Y graft, and that was that one patient developed limb thrombosis. And so you can see that in the image data here. I'm showing here the postoperative imaging for 4 of the patients. So you can see the Y graft implanted. This is MR imaging that was done post-surgery. And we were also able to do a number of simulations on the postoperative image data, both for validation and also for further study. Here you can see the patient that had thrombus. This patient is actually clinically asymptomatic and doing fine. But this was something that we went back and studied further in simulations, and we are fairly confident that we've come up with an explanation for why this happened that can hopefully be avoided in the future. We were able to perform some validation against our lung perfusion data that was collected in the clinic, and so here you can see a comparison between simulation and lung perfusion data in 3 patients with quite promising agreement. So to come back to the clinical questions that we posed originally, we believe that we can improve hepatic flow distribution with a Y graft design. Our optimization study showed us that we don't believe the Y graft should have unequal branches, but we also do think that the design should be customized for individual patients. And so particularly when it comes to, examining the risk of low wall shear stress or high residence time leading to thrombosis. We no longer believe that it's likely that the Y graft will reduce workload on the heart based on our multi-scale modeling studies. And we were pleased to demonstrate that the surgery was technically feasible. And again, this has been also shown by another leading institution where they've done about 30 patients at this point using a slightly different design. I wanted to take a step back and sort of give you the timeline, because I think, there may be a tendency in the community by some who think that clinical translation should be sort of quick and easy. And so, I just wanted to give sort of a realistic picture of what was involved. So we proposed the Y graft idea to Dr. Reddy in 2006 and, had those initial discussions. We did extensive simulation studies and optimization studies, and we published the first studies from our lab, and there were others that came out of Georgia Tech around the same time on our area preserving graft, published in 2007. The first surgery was performed in June of 2010 at Packard Children's Hospital at Stanford. And we published the clinical outcomes and validation studies in 2014, again, because we needed a long enough time window to really evaluate how these patients had done in the few years, intervening years post-surgery. And again, I'm happy to answer any questions about this. I wanted to also give a few thoughts about what I think it takes for a successful team to achieve clinical translation. From the engineering side, I think it's incredibly important that engineers be invested in the clinical problem and not just to look at the clinical problems as something interesting to solve, but really, be invested in the goal of improving patient care. I think the engineers need to be interested in, fundamentally interested in learning about clinical challenges and needs. They have to be willing to get their hands dirty by going into the clinic, dealing with the IRB, consenting patients, observing procedures and surgeries, and really embedding ourselves in a clinical environment so we truly understand what the issues are and how we can help. From the clinician side, it also takes quite a bit of dedication. It helps to have clinicians who have some quantitative training and interest in understanding our tools. I have been very fortunate to work with a couple of different clinicians who had engineering degrees prior to medical school, and I think that's something that has really helped, propel that interest. It also takes time and resource investment on the part of clinicians, both to provide clinical data, to meet regularly, to also deal with IRBs and other issues of data collection, extra imaging, et cetera. And on the part of the clinician, it also takes, a realistic vision about what problems we can solve with engineering tools and what problems we can't solve. So I think one of the major challenges is really trying to blend, these are the tools we have or tools we can develop and the clinical questions we can answer, and really trying to partner those ideas to make a difference is, one of the most important aspects of this. So I wanted to now give you a glimpse into what we're doing next. And so we're going to return now to looking at the stage 1 surgery. And I'm going to show you an idea that we recently published and are hoping to translate into the clinic in the next few years. So we're going to talk now about the stage 1 surgery, which is the Norwood. And this surgery actually has the highest mortality of all 3 stages of this single ventricle surgical pathway. Stage 1 has about a 30% mortality rate, so this is a very challenging patient group. They're neonates with a very delicate physiology and are very challenging to manage clinically. One of the reasons their physiology is so delicate is that their systemic and pulmonary circulations are in parallel. So remember that they only have one ventricle. We've put in a shunt connection between the systemic and pulmonary circulations. And so that means that the one ventricle that you have is having to do the work to pump to both circulations in parallel. So there's about twice the normal ventricular volume load. That can also lead to myocardial ischemia and coronary steal. It can also lead to sudden death if this tiny shunt that has been implanted were to clot off. That would cut off the infant's only source of oxygenated blood flow. And then there are also issues with lower oxygen delivery and imbalance of flow distribution due to this unusual physiology. So one of the first things that we attempted, and these were simulations performed by my student Mahdi Esmaili Moghadam in my group here at UCSD. So the first thing that we attempted was to do optimization on the existing surgery. So we ran a series of optimization studies with a couple of different cost functions aiming to maximize oxygen delivery. And while the optimization was technically successful, we found that there was not a whole lot of improvement that could be gained by just tweaking the existing surgery compared to the standard clinical implementation. So we got at most 1% improvement in oxygen delivery, which was really not sufficient to make a clinical recommendation. We then examined another option, which is actually one that's performed at many leading centers, and this is the idea of implanting a second shunt. So you can see here the BT shunt, and there are 2 options for providing an additional source of pulmonary blood flow. So that's by doing a central shunt or by leaving the ductus arteriosus patent at the time of surgery. And so we examined both of these scenarios with a range of diameters for both the central shunt and this PDA. And we actually found that the addition of a second connection actually made things worse. So we found that multiple shunts decreased oxygen delivery, increased cardiac work, and increased residence time in this segment of the pulmonary arteries between these shunts. And we worked with clinicians, so Tianyan Shah at Great Ormond Street Hospital, who performed a clinical study retrospectively evaluating patients with and without this competitive flow. And so we found that the patients without the competitive flow had a much better survival curve than those with multiple shunts. And so this was a case where the simulations really helped to provide an explanation, mechanistic explanation for why multiple shunts might be causing this difference in clinical outcomes. So, this was good news in the sense that we were able to provide an explanation, but bad news in the sense that multiple shunts did not seem to be an avenue towards improving outcomes for these patients. And so this led us to another concept, and this was one that was developed by my student Madi together with me and our surgeon, and this is to use the idea of an ejector pump. So in fluid mechanics, this is quite a common concept. The idea is to take a low pressure flow and drive that flow with a high pressure, smaller flow stream that then elevates the pressure of the outlet. And so we then asked the question, could we leverage this ejector pump concept to design a novel surgery for single ventricle stage 1 patients? And so we developed something called the assisted bidirectional Glenn. This is essentially doing the traditional Glenn surgery, but doing it earlier at the time of birth, but adding to that a second shunt that would use this ejector pump concept to drive flow in the pulmonary arteries. So our goal would be, if this was successful, we could potentially reduce the number of surgeries from 3 to 2, increase pulmonary flow, volume unload the ventricle, and potentially decrease thrombotic risk, since if this small shunt clots, you're left with the traditional Glenn connection that you would do at 3 or 4 months anyway. Now, it's important to realize that there's a reason we don't do this Glenn connection in patients as neonates, and that's because they would experience inadequate pulmonary blood flow. And so, just doing this part without the additional shunt has already been shown to be insufficient and lead to poor outcomes. And so our attempt is to combine these concepts, use the ejector pump to increase pulmonary flow, and then reduce the total number of surgeries. So we used simulation to compare the 3 different surgical options: the traditional VT shunt that's performed now, the ABG that we're proposing, and the Glenn surgery that's currently done at a later 3 to 4 months of age time point. And so the results of our simulations have been very promising. These were just published in the Journal of Thoracic and Cardiovascular Surgery in September. We were able to show in simulations, again, that we did reduce the cardiac workload by about half. We had the maximum oxygen delivery using the ABG and maximum systemic saturation compared to either the VT shunt or the Glenn, with the caveat that we are increasing the SVC pressure a little bit, and this may be undesirable. It's something that needs to be studied further. However, we have some ideas for how we can modify the design to hopefully reduce this pressure increase a little bit. So what you're seeing in the movies here is the traditional Glenn surgery with relatively low pulmonary flow compared to the ABG on the bottom, where you can see that this high velocity flow stream is injected into the SVC and is driving the pulmonary flow. So our ABG design, speaking cautiously, looks promising. It appears to combine the advantages of both the Glenn and the shunt circulations by increasing oxygen delivery, pulmonary flow, and ventricle offloading. The impact of the increase in SVC pressure remains unknown, and that's a topic of further study. We feel that there's potential to eliminate one surgical stage and potential to reduce the risk associated with this extremely challenging shunt physiology. I wanted to now take a step back for a moment and compare, what were some of the risks and challenges that we faced in developing the Y graft and translating that to the clinic versus what will be our path forward in the ABG translation. And one sort of main point we want to make here is that even though this is the same patient population, the path forward is very different, even for these two different approaches. So the Y graft was viewed to be a modest enough deviation from current clinical practice that we were able to go directly from simulation to human studies without doing an animal study, without needing new FDA device approval. And so now we really need to just consider the risks and benefits of different aspects of the design and different clinical outcomes, such as hepatic flow distribution versus risks of thrombosis. And so we're at the point now with the Y graft design where I'm hoping we can run a multi-center randomized trial to compare patient outcomes. Now with the ABG, it's a different story because the deviation from current clinical practice is viewed to be much larger and much higher risk from the point of view of the surgical community, especially because it involves surgery on neonates. And so here, this is a case where we really are going to need to do an animal study to gain confidence and gain experience on the part of the surgeons and evaluate the hemodynamics. We may also need to go through a device design FDA approval process, although it's not entirely clear yet. That depends on the design. So moving forward on the ABG, we are going to continue to do simulations, but we are also going to do two experimental approaches. So one is to do in vitro studies. We're working with Richard Figliola at Clemson University, who's developed mock circuits. We are looking to do additional device optimization and to assess thrombotic risk, both in vitro and in silico. And at the same time, we're exploring animal studies. So we're working with Olaf Reinhardt at Stanford University to create an ABG in a sheep model. There are a number of challenges that come with this in single ventricle animal models. These are not easy models to work with. I just wanted to give you a glimpse at the in vitro experiments. These are from the lab of Richard Figliola at Clemson, and they have a mock circuit closed loop setup where they've already evaluated the ABG concept. We've been collaborating with them on this, so looking at the traditional VT shunt Norwood procedure versus the ABG and the bidirectional Glenn. And we've done some preliminary comparisons with their experiments showing very good agreement. We've also looked at, varying some of the design parameters. I think it's also worth noting some of the challenges of pediatrics research as a whole. We often deal with extremely small patient numbers, and a way around that is, really requires coordination among multiple centers through things like the Pediatric Heart Network. We also have a number of challenges, and justifiably so, related to ethics of clinical data collection in children. For example, if you want to do additional MRI evaluation, often that requires sedation for a child, and so we can't warrant subjecting them to that additional risk, often for research purposes. Of course, all of these things require IRB and parental consent. There are challenges relating to pediatric devices, in that devices are often designed for adults and then used off-label, but children are not just tiny adults. They have their own, physiologic challenges, different mechanobiologic responses, different chemistry, blood chemistry, et cetera. And then, for something like the ABG moving forward, if we needed to go the device route, there's a very small market for these patients, and that makes device design a harder sell for industry. And so that may be cases where, the NIH or other agencies the FDA need to sort of step forward and provide a pathway for those kind of devices. So I think that simulations overall can help to address these issues by accelerating the design process, maybe allowing us to refine the design enough prior to a large randomized trial that we can maybe avoid the need for multiple clinical trials. Of course, we won't avoid the need for clinical trials altogether, but can possibly accelerate that process using simulation. So I just wanted to summarize here by saying that multi-scale modeling and simulation can be used, I believe, to test novel and sometimes high-risk surgical procedures when animal or human application may be technically or ethically infeasible. I've showed you 2 stories of surgical methods we've developed for single ventricle patients. We believe the Y graft is now ready for a larger clinical trial, and so we are working towards that. We also believe that the assisted bidirectional Glenn appears to meet the design and performance goals from our simulations, and so we're now moving towards further exploration via in vitro mock circuits and animal studies. And I hope that both of these stories have really shown that the translation process needs to be tailored to the clinical need. It requires a huge amount of coordination and cooperation between engineers and clinicians. It also takes time and flexibility, and sometimes you have to be willing to go out of your comfort zone a little bit, like being a CFD person who is now faced with running an animal study. And so sometimes that requires really going out and bringing in the appropriate collaborators at that point to ensure the success of the project. So I wanted to end by acknowledging our funding sources. You can see the funding sources on the slide, but in particular, the clinicians that we've worked with, Jeff Feinstein, Tanyan Shah, and Mohan Reddy have been instrumental in the development and really providing time and resources from the clinical side. My students and postdocs who've worked on this, particularly Wei Guang Yang, who's worked on the Y graft, and Mahdi Esmaili Mogadam, who worked on the ABG. So we'll stop there, and I'd be happy to answer other questions. Joy, you want to give some instructions?
Well, thank you, Allison, for a really insightful talk. Let's go ahead and get started with that Q&A session. We have just a few minutes. And as a reminder, all of the questions are going to be text-based. So if you have a question for Allison, go to that Q&A box that's on the bottom right of your screen. Type in your question and make sure you select to ask all panelists. Otherwise, we actually won't see your question. And while we're having people type in those questions, I'm going to go ahead and put my own question out there to you. It seems like that collaboration with Dr. Reddy and Dr. Shah were very, very critical to moving these new designs into the clinics and getting as far as you have. Can you tell me a little bit about what their backgrounds are in engineering and how did you actually go about establishing the collaboration with them?
Sure. So I've actually been working with Jeff Feinstein since I was a postdoc, and he also was one of the early collaborators with Charlie Taylor, where I did my postdoc. He has an undergrad degree in computer science, and also a master's in biomedical engineering. So he kind of came, with a already predisposed towards computational simulations and bioengineering. And so that was a huge help in really, both understanding some of the challenges in what we were doing and also having an appreciation for the need. That relationship was really instrumental in getting the Y-graft translated to the clinic. And similarly for Dr. Shaw, so he's a surgeon at Great Ormond Street Hospital in London. He has a long history of working with engineers and attended MIT as an undergraduate. He's worked for a long time with the group in Milan, Italy, on some of the pioneering engineering studies that really led to, the adoption of early adoption of some of these tools in the clinic. And he's been the PI of our Leduc Foundation grant that was actually the first engineering group that the Leduc Foundation funded, and I think has been quite successful looking at multi-scale modeling for single ventricle patients and clinical decision support.
Great. Are there any other questions? I see someone typing. Hold on a second.
I can maybe add another thought while we're waiting, which is that I have been really impressed by how receptive a lot of the clinicians that I've worked with have been to these tools. I think they recognize that they're often forced to make decisions about patients with incomplete information. And often those are life and death decisions, and so they really recognize, I think, the need for more quantitative tools and more quantitative risk assessment in their patients. And so I've found, very happily that clinicians have been quite open-minded to sort of anything we can do to help them make better decisions. And I think, we need to appreciate their challenges of, they have a patient in front of them and they have to make a decision today whether or not they have enough information. And so those are, I think we need to be sensitive to some of their challenges as well.
Yeah, that's a really good point. And kind of presenting it in that way, I think, would be really useful. We've got a number of questions lined up. Unfortunately, we're running a little bit short on time here, so I'm just going to go with the first question here from Amit. What was the most challenging experience you had when you tried to convince a clinician about the adequacy of your results?
I think that validation is the most challenging part of a lot of this. And, it's one thing to do validation with an in vitro model, but really often what you're validating there is your ability to solve the equations correctly. But what we really need to do is show that we can produce the physiologic conditions in an actual patient. And so I think there's a huge need for more in vivo validation data, and maybe some of the animal studies can help bridge that gap. But I think the most challenging thing is, we have a lack of validation data that we can use to show to clinicians who ask those questions. And, so that goes both ways, because we also need clinicians to get on board with helping us, get that data, keeping in mind the ethical challenges.
Great. unfortunately, we are out of time. We've got a bunch of questions lined up now. Can you go to the next slide, Allison?
Sure.
So what I'd like to encourage you all to do is continue this discussion online. We've got discussion forums at our website. The site is listed there, https://wiki.smtk.org/CPMS. I have your questions, and I will forward them to Allison so that she can address those. And perhaps if she's okay with that, maybe we'll even post those on our forum online. That'd be really helpful. One activity I do want to mention, if you haven't had a chance to take our survey yet, we're conducting a survey to try to establish what are some of the rules for credible practices of modeling and simulation. That survey closes on February 15th. You can access it again from our website. And we'd also appreciate you taking a few minutes to fill out the survey about this webinar, which will appear after the event ends. So thank you again, Allison, for a really stimulating presentation. We've got a bunch of questions lined up, and it's unfortunate we weren't able to take more questions. And thank you again to all of you for your participation. I hope you will continue this conversation afterwards.
Thank you so much, Joy.
Thanks, everyone.